Farmer's asked that all of the faculty give at least one grand rounds during the course of the year, and as you can tell, she's up front early in the academic year. She won't say this, but her work at UC Davis in developing a pediatric hospital and the initiative on developing a ACS, American College of Surgeons verified pediatric surgical center has really been quite remarkable. First or second one in the country to be verified by the college as a pediatric surgery center. The leader of it, Keith Oldham from Milwaukee, I think is tied for the first one between the two of them. The transition and transformation of UC Davis to the pediatric activities has entirely been the work of Dr. Farmer and the group that she's recruited to help make it happen. And today is going to be a grand rounds that's going to focus a little bit upon the long-term initiatives that go. So, Dr. Farmer, thank you.
Thank you. This is a story about what I've been doing a little bit on the side of my day job as department chair and pediatric surgeon as the president of the American Pediatric Surgery Association, which I was privileged to do for the past year and is the largest surgical association devoted exclusively to the care of children. With that job, you are given a powerful bully pulpit, and it's a bit of a responsibility to think about what are you going to do, what impact are you going to have with the privilege of having that bully pulpit for a year, and how my work in this related and global surgery ultimately brought me to a new understanding and thinking about how we care for children in this country. And finally, as my title suggests, to propose an audacious goal related to this. I had intended to apologize in advance for the fact that this talk is relatively child-centric. After all, I am a pediatric surgeon. But I hope I can convince you that there should be no apology, because children, in fact, are our hope and for the future, and really, for most of us, our strongest reason for being. So I hope I can convince you that thinking about how we care for children is not just a parochial perspective, but really something important for all of us. So this morning I want to share with you a vision for our professional community as surgeons and for society. And I want to propose an audacious goal. Now, Webster described an audacious goal as an intrepidly daring, spirited, adventurous goal that shows contempt for the restraints of law, religion, and decorum. So that's just to give you a bit of a preview. So let me start with the story of a boy from Bangladesh. So this is a baby boy who was born with a minor cleft lip and a small axillary tumor. He was one of 4 children. His parents really didn't think very much of it. They were busy. It didn't interfere with his ability to do things until it got to be big, as you can see here, and they brought him to the hospital. Well, at the hospital, the operation was delayed because they felt that he needed potentially to have blood available for a blood transfusion, and the parents couldn't arrange blood. They hadn't planned that in advance. So they had to leave the hospital. The parents were garment workers, and they had to go back to their jobs. So, and he wasn't dying. So they brought him again back in 5 months. This time now, he had developed chest infections, the wound had started to become necrotic, and he had an additional stay in the hospital because they had to treat the infection before they could treat his tumor. During that time, the mother lost her job, she stayed, the father went back, and another child got injured, just an injury like routine kids get. They sent an older sibling out as domestic help to help pay for the family's financial challenges, and of course the father incurred debt to try to make this happen, to just care for his child. Eventually the father lost his job because of frequent hospital visits by the time the child's first treatment was finished. So as a surgeon, I have had the opportunity to collaborate with peers from the most privileged and the most impoverished countries in the world. And I would say that one of the most important lessons that I have learned in my global health journeys is that I did not and do not have all the answers. And that, in fact, my international colleagues are often the best equipped to identify the right treatments for their patients in their practice environment. So let me tell you one of my stories. So as a visiting surgeon to Senegal in 1989, I once brought silastic sheeting to help make silos for giant omphalocele. And I was, of course, preemptively congratulating myself on what a great idea this was, because this was the modern care in the United States at the time. Tragically, my patient died. The local hospital did not have the ability to ventilate and sustain the already relatively malnourished child for the time it took him to recover from what was relatively major surgery in that environment. The history of global surgery is replete with such stories of outcomes compromised and lives lost because of the best intentions of international do-gooders. I and many of my colleagues who work in the global surgery arena have since learned that it is the local innovations that are often the most successful, less morbid, and in fact, more cost-effective. Indeed, the historical teaching in the U.S. that giant omphalocele must be closed relatively urgently, lest there be loss of domain, leading to the intestines in the wheelbarrow syndrome, with this sort of iconic picture that was in all the early textbooks, was easily disproven to me in places like Senegal, where patiently painting these giant omphalocele with betadine and adding compression ultimately results in reduction of almost all of these omphalocele and leaves just a simple ventral hernia that can be cared for later on. So in a similar vein, I believe that the lessons learned from global pediatric surgery actually apply to both low and high income countries, and that by heeding some of these lessons, we can collectively transform the care for children around the world. So I take you back to 2015. In many ways, 2015 was a landmark year for global surgery. In that year, the World Health Organization published the third volume of the Disease Control Priorities book. So this is an effort every so many years to catalog all of the diseases in the world and prioritize how we should tackle those in order to affect the healthcare of the world. For the first time ever, an entire volume was devoted to surgical disease, and I had the privilege of writing the chapter on congenital anomalies. For the first time, the global health world was starting to realize that there was more at stake than just AIDS, tuberculosis, and malaria. In fact, according to the World Health Assembly Resolution 68.15, surgery and access to emergent and essential surgery was declared a human right. This was a big deal in the world of public health because funding for these efforts usually follows the DPC-3 recommendations and the sort of world's decision on what are important issues for healthcare. And then finally, the Lancet Commission on Global Surgery showed convincingly that investing in surgical care was affordable and an indivisible part of healthcare. And I'd like to show you a video by the Lancet Commission that describes the current state of surgical care in the developing world, because they did it much better than I can. So let's just take a minute.
Over the past 2 decades, global health has focused on individual diseases. Surgical care has been afforded low priority in the world's poorest regions, leaving 5 billion people without access to safe, affordable surgical and anesthesia care. Patients requiring surgical treatment will face multiple hurdles: delay in seeking care, delay in reaching care, delay in receiving care. Reaching the hospital does not guarantee treatment, as many lack the proper infrastructure to provide emergency surgical care. As a result, many easily treatable conditions become diseases with high fatality rates. As many as 90% of maternal deaths could be averted by timely intervention. For those who successfully obtain treatment, 1/4 will experience financial catastrophe as a result of receiving surgical care. To save lives and prevent disability, an additional 143 million surgical procedures are required annually in developing countries. Today's surgical workforce would need to double in 15 years to reach our target of 80% coverage of timely access to essential services by 2030. The total costs required to reach these targets are significant, at approximately $350 billion by 2030. However, the costs of failure are even greater. The lost output will cost developing countries an estimated $12.3 trillion. Investing in surgical services is affordable, saves lives, and promotes economic growth, making surgery an indivisible, indispensable part of healthcare.
So it's a pretty powerful message. But what about children? So if you look at this map, you appreciate that 1/3 of the world's population are children. And the majority of those children live in low and middle income countries, or LMICs as it's described. Indeed, children under the age of 18 constitute more than half of their populations, more than 50% of the population in most LMICs. These children represent the future for their families and for their communities. If surgery has been called the neglected stepchild of global health, then children's surgery is the child still unborn. Addressing the unmet needs among children is particularly important because simple procedures, such as removing an appendix or stabilizing a fracture properly, can radically alter the course of that child's life, transforming them from a cripple on the street that any of you who have been to developing countries have seen, to enabling them to contribute and participate in their community's social, political, and economic network, not just for a short time, but for many years. However, children are often just assumed to be healthy because they are young. We don't think about kids getting disease, and perhaps for that reason, they have often been overlooked as a target for previous efforts to expand access to safe surgical care in LMICs. And even when children's care is the focus of many of these efforts, they are largely directed by experts from what we call the global north, the high-income countries, making recommendations about care in the global south, in low-income countries. And the mismatch there is often significant. And as anyone who's done this kind of work, and there are many in this room that have, you can attest to the fact that the global health landscape is literally littered with the detritus of abandoned medical missions, of rusted ventilators, of unrepaired incubators that you see in any of these locations. It'll say the gift of the Japanese-Senegalese mission in 1984, and there's all this gear that can't be maintained. So, the Global Initiative for Children's Surgery is what I'm going to talk about next. At a 2015 British Association of Pediatric Surgery meeting, I was asked to describe some of the pressing issues in pediatric surgery in the United States. So of course I immediately talked about the controversy that's brewing in pediatric surgery that I realize most of you are unaware of, about whether we have too many pediatric surgeons or not enough pediatric surgeons, the workforce dilemma. I also highlighted the relatively new at that time non-operative approach to gastroschisis, when kids are born with their intestines on the outside, and we just put it back and cover it with the umbilical cord, and that magically heals that defect, often without a need for any surgical operation. And while I was doing that there, I could not avoid noting that while the fatality of gastroschisis in the United States has dwindled to near zero, I mean, we don't even think of this as something that kids are going to die from anymore. If you look at the overall mortality of this congenital anomaly worldwide, it remains almost 100%. the improvement that we've made in this country is trivial compared to the overall incidence of this disease. So struck by the injustice of this comparison, that a child's chance at survival is really predicated on the lottery of the circumstances of where you're born, I and two other pediatric surgeons, one from the UK and one from Canada, began a conversation about what could we do to tangibly improve the health care for children everywhere. These conversations eventually culminated in the founding of the Global Initiative for Children's Surgery, or GICS, or JICS, or we don't really know how to say it. GICS is based on a vision of children's providers from low and middle income countries as the primary drivers in the development of new programs and initiatives matched with potential funders, and of LMIC experts as the guides for the most effective interventions in their practice context, really changing how most of global surgery has been done up till then. GICS involved providers from all kinds of children's surgery, from neurosurgeons to urologists, from anesthesiologists to physical therapists, not just pediatric surgeons. And the core goal of this loose assemblage of people was to initiate and accelerate long-term sustainable progress towards safe surgical care for children around the world. We began, like surgeons, developing an operational sequential plan. We would collectively analyze the current state of children's surgical care around the world, develop global and local priorities for improving surgical care, and then identify and bring together resources to achieve these goals. So a small group of people, led largely by these two residents from UC Davis, Laura Goodman, who at the time was getting her MPH at the Harvard School of Public Health as a Fulbright scholar, while also working in Mongolia on the side, and Guy, who was also getting his MPH at the University of Washington, were sort of roped into this activity and really did the lion's share of the footwork that made all of this happen. We all set about organizing the inaugural in-person priority setting meeting, which was made up the plan of mostly geographically diverse providers from low and middle income countries in various specialties. So prior to the meeting, they developed an online 19-question survey that was sent to all of these folks from around the world. And the survey responses were then quantitatively and qualitatively analyzed to identify key themes and to set the agenda for this meeting that we were going to have with all these people from around the world, having no idea how we were going to raise the money, how we were going to do this, or if anybody would really come. But youth springs eternal with hope. So the respondents answered interestingly and not surprisingly. First, they cited that workforce issue was the primary barrier preventing children from getting the care that they needed. They also cited facility issues, some patient factors, the functioning of the overall health system, and dealing with communicable diseases as factors that prevented children from getting their care. More specifically, the inability to provide TPN was the most commonly identified supply problem. 95% also reported they had no access to what we consider modern pediatric intensive care unit activity. 88 did not have any neonatal intensive care capacity, and even 60% said they did not have access to basic medications or basic instruments appropriate for children. When asked which patients were now the most difficult to treat, most providers identified neonates, newborns, as well as patients with congenital anomalies, birth defects. Also patients who were born prematurely and patients with burns as the most challenging patients to treat. So you'll notice on this slide that gastroschisis is not even listed because these children often do not even survive to the hospital to get listed on the issues of problems. It's a true hidden mortality. Additionally, poverty-stricken patients were identified as a challenge, and patients with psychosocial issues, rural patients, were often identified as neglected and difficult to treat populations. So what are some of the solutions? So these four main areas were identified as target solutions to these challenges and set the agenda for the subsequent meeting. Specifically, the surgical workforce, supplies and equipment, accessibility to care, and healthcare system infrastructure and research. Just think about those for a few minutes and let it sink into your head. Increased in-country physician training was the most commonly identified method for improving the surgical workforce. Indeed, respondents voiced concerns repeatedly that the current scarcity of in-country training opportunities and reliance on overseas medical training had clearly resulted in brain drain, that the best and the brightest were selected from many of these countries to go off to Great Ormond Street in London or go off to places in Canada, and that the majority did not return to their country. This practice must stop, and we really need to think about changing the paradigm of how we do this kind of training. Because the Royal College of Surgeons had graciously donated meeting space and specialized and subsidized housing, London was chosen as the first site for our meeting. The inaugural two-day meeting of GICS was held in May of 2016 and was attended by 50 pediatric surgeons, urologists, neurosurgeons, orthopedic surgeons, plastic surgeons, anesthesiologists, critical care docs, and nurses from 24 countries, ranging from Uganda, South Africa, Kenya, Bangladesh, Peru, Papua New Guinea, as well as Canada, Britain, Switzerland, Germany, and the US. So, providers participated initially in large group sessions. Each then delivered an individual presentation and then participated in one of those four working groups that had been identified from the work that Laura and Guy did ahead of time. Individuals presented strategies employed in each of their local environments, and this was fascinating. In Vanuatu, we learned about the challenges of inter-island transport. If you think we have challenges in transport, that they have extraordinary challenges. There are only 4 general surgeons for a population of 280,000, so that's 1 for every 70,000 surgeons. And one of those general surgeons sort of subspecialized in children and became the de facto pediatric surgeon in Vanuatu. In Bangladesh, we learned some amazing things about the betel leaf stoma care option. It provides great anti-inflammatory effects on the skin, as well as the bananagram method for determining whether or not you're ready to close a stoma, right? If you put the mushed banana in the one end of the stoma and it comes out okay the other end, then it's probably safe to close the stoma. You know, what do you do when you don't have barium and regular MRIs and fluoroscopy? As well as the results of sort of rural training program that they have in Bangladesh and a way to get community health workers to help provide care for rural folks. In the Congo, we also learned about a heroic group of surgeons who are working hard to improve that country's image. They have developed a provision of greater care for children and have advertised this as highlighting something that is good about Congo when so much of the press that comes out of that country has been negative. Each working group was led by a participant from an LMIC. Iterative working group discussions interspersed with large group feedback culminated in identification of priorities for each of the topical areas and tangible work products for GICS. And envisioned work products included white papers, collaborations, a consensus statement on the optimal resources for children's care, collaborative research, and developing a social media presence. So, what were the outcomes? So, identified strategies included developing training programs to train more new providers and develop skill-building programs for current providers in country, founding dedicated children's hospitals or disease-specific centers of excellence to deliver care and train interdisciplinary team of care providers, directing financial resources to purchasing of the equipment that you need to do the job, and also disposables that we often take for granted. In many countries, the family has to pay for whatever disposables you need and bring it to the hospital in order to get care. And then certainly investing in the renovation and maintenance of operating theaters, of operating rooms. Again, rings a little familiar. PICUs, NICUs, and burn units. Creating networks of rural clinics with a central hub and developing mobile operating theaters to provide elective surgical care to rural environments. And developing a national structural birth defects registry. In many environments, it's hard to even know what the baseline is. And to develop formal referral and triage systems. And to provide free care for children so that families would not be impoverished by a child's illness, like our boy from Bangladesh. So, approximately a year has now passed since GIC's first meeting, and in that time, actual progress has been made. Members of the group have facilitated 3 new training partnerships between the UK's Royal College of Surgeons in India, one between Uganda and South Africa, so in-country, in-continent training, and also Kenya and Uganda. And this is just the beginning. They've also received a grant to participate and partner with Operation Smile in South America, in Nicaragua. They've also expanded the Global Pediatric Surgery Network, which was an effort that started by a single pediatric surgeon, into advertising training opportunities and expanding it beyond just pediatric surgery, but to other surgical subspecialties as well. And they have completed the publication of a second edition of a collaborative text for pediatric surgery in Africa. In that time, GICS also held a second in-person meeting, this time in DC, hosted by the American College of Surgeons. Again, we had the site donated by either the Royal College of Surgeons or the American College of Surgeons, and we funded the people to come from the low and middle income countries, frankly, largely by donations from the people that were involved in this. It was shockingly hard to raise money for this endeavor. You would have thought raising money for children's surgical care would be easy. It was not. At the second in-person meeting, work groups composed of providers from different surgical subspecialties and representatives of different NGOs determined the minimal standards for workforce training, for the complexity of procedures, equipment, and the presence of allied health professionals in community-based primary care and at what are known as district hospitals, secondary and tertiary hospitals, and at specialized children's hospitals. These discussions resulted ultimately in the development of the global Optimal Resources for Children surgery document, which defined the needed resources within every level of a theoretical health system and within each specialty. So we brought folks from cardiac surgery, and Nilos's group from Operation Heart to Heart brought in surgeons from developing countries to help define the cardiac aspect of the program, and we had people from all around. Ultimately, we intend this resulting Optimal Resources document to be incorporated in the developing national surgical plans that are now being worked out in countries all around the world. And this is some of the work that Jamie Anderson, who I know is here somewhere, is doing in her year involved with the Harvard program and John Mara's group. We intend for the GICS Optimal Resources document to be used as the tool on the children's side of that effort. Because if you look at the bellwether procedures that were presented in the work from the Lancet Commission, that doesn't apply to children. You've got to have, you can't do an operation on a 2-year-old if you don't have an endotracheal tube that will go into a 2-year-old. So this is a partnership that I think will be great, and Jamie is really being the bridge for this effort. So originally organized by the team you see here and supported by what turned out to be an amazing global team. So you can see Laura and Guy and then her colleagues who were residents from a variety of other countries. really, and they were the true power behind this effort. GICS now consists of 153 members from 44 different countries. While the need to improved surgical capacity for data collection and collaboration have all previously been recognized, GICS is unique in its professional and geographic inclusivity of its membership and its reliance on realistic implementation from low and middle income provider leadership and its sort of bottom-up identification of issues and solutions. GICS, again, thus far has relied on volunteer labor and personal donations. The organization has just now become officially incorporated as a not-for-profit organization, again, largely through the work of Guy. And this incorporation allows GICS to publish the Optimal Resources document in collaboration with the World Health Organization, which immediately gives it sort of a world imprimatur that we would not be able to get otherwise. And planning for the third meeting in Bangalore, India, is underway. Again, a lot of work by Jamie Anderson. So, what about care in the United States? In reflecting on the formation of GICS and all this effort that I was putting in for the last year, I was struck by what is now a completely obvious realization, that the solutions that we were collectively devising to improve surgical care in low and middle income countries hold as much promise for improving the delivery of care to children in the United States. Among high-income countries, the United States has the highest reported infant mortality rate. It is sort of astonishing to believe. And most of us, on one level, don't believe it. We think it's something wrong with the statistics, or we just get better data. And while there may be some truth to that, it is an astounding reality. And indeed, if anyone who has worked at Shriners can attest, children who are the most underinsured in this country or uninsured in this country, high-quality surgical care remains largely inaccessible to them. I personally now have operated on over a dozen children over the age of 5 with undescended testicles. These boys will be sterile. You can get emergency care if you are underinsured or uninsured in this country, but you can't get elective care. If we look at a map of underage mortality, we see that when adjusted based on socio-demographic index, the observed to expected mortality ratio in many parts of this country are on an equally poor scale as parts of South Africa, Turkmenistan, Kazakhstan, I had to look up what those countries were, and Mongolia, where Laura spent most of last year. I want to thank Guy again for getting this amazing math, because seeing it in graphical imagery really brings it home. So you have to ask the question, so within the U.S., what are the barriers preventing children from getting this kind of timely, appropriate surgical care? So many of the same themes come up again: a shortage of trained surgeons in all environments, inadequate health insurance coverage, and low patient socioeconomic class. They've all been identified as challenges to the provision of high-quality care for kids. So in devising strategies to these barriers, what can we take from what we've learned from our colleagues in low and middle income countries? And how can we utilize those lessons learned about effective intervention strategies to inform our own efforts to ensure that all children have appropriate access to surgical care? The work of GICS has highlighted a number of key proven strategies for improving accessibility and quality of care for children. And in the U.S., one of the most relevant of these strategies is initiating the establishment of universal coverage for children's health care. Now, for some Americans, the concept of universal health care conflicts fundamentally with our American values of meritocracy and individual choice. However, I submit that children are innocent, that they should not be disadvantaged based on the sheer chance of being born to parents without the means or sometimes just the know-how to ensure that they receive essential health care. Now, Medicaid has indeed been associated with a significant drop in infant mortality in this country. But while federal regulation mandates that children must be considered eligible for Medicaid coverage, individual states retain the right to establish the level of impoverishment needed to qualify as needy. So whether a family qualifies for Medicaid and the amount of support they receive therefore varies dramatically from state to state. And as a result, children still fall through the cracks. And in 2015, 1 in every 20 children in this country still did not have insurance. So in the United States, uninsured children are 3 times more likely to die following surgery. And this excess mortality suffered by uninsured children accounts for almost all of the 40% of child deaths, here. And even children who do have at least Medicaid, they, interestingly, experience disparate outcomes compared to their peers with private insurance. Children on Medicaid experience greater morbidity following surgery than their counterparts and are at greater risk for perioperative death. So clearly, the future of the American healthcare system is very unclear. Just recently, of course, an attempt by Congress to repeal and replace the Affordable Care Act floundered, and nothing is transpiring. Even as the debate about the future and the form of healthcare in the United States continues to rage, I believe that this issue of ensuring coverage and access for each and every child cannot wait. I don't propose that I can solve the problem for the entire healthcare world, but I think there's a way we could do it for kids. No child should be prevented from accessing essential healthcare because of financial concerns. Think back of the kid from Bangladesh. In this country or anywhere, they have no control over this. So I propose an audacious goal. I say we should pilot what I would call MediChild, a national system of healthcare coverage for all children under the age of 18. This system would ensure that all children, regardless of their family's employment, location, of type of health insurance, would have access to high-quality, necessary surgical care. A child's access to appropriate care should not be limited by the fact that her parents are temporary vineyard workers, as we see here, or that the family moves across state lines because her parents are in various stages of residency training and they just matched in South Carolina. Or perhaps they've reached their $1 million cap that they didn't even know they had on their insurance policy. Or that the parents juggle multiple part-time jobs and do okay, but none of those part-time jobs come with comprehensive health benefits. So in order to prevent these type of ordinary children from being left behind, this program must be federal. It can't be state by state. It has to be federal, like Medicare is federal, instead of partially or completely state-based, like Medicaid currently is. Beyond funding, I would suggest that MediChild must mandate that children's care be delivered in an integrated system. Just as GICS defined the optimal resources document for a global system of care in low and middle income countries, so too should MediChild ensure that children receive care at the best hospitals suited to address their medical needs. We can build on the foundation. This has already started through the APSA ACS Optimal Resources Program, the Trauma ACS model that is also looking at developing a system of trauma care for the nation, and our pediatrics colleagues have developed a neonatal intensive care unit, a similar verification program with an integrated system to achieve this goal. With an integrated system, you can rationalize resource distribution, avoid competition, and duplication. The need is as pressing as it has ever been, and I personally think that the time is now, and that there really is a momentum around thinking about how to do healthcare differently, because clearly the system is not working for us. Let us truly live up to the greatness that we aspire for this country to be. We could do this immediately by leading the world in the development of an integrated system to care for our most vulnerable, our most innocent, and frankly, our most important citizens, which are our children, which each of us deal with, whether personally at home or through our work. So in conclusion, I have proposed an audacious goal. The lessons learned from the international efforts to improve the capacity, accessibility, and quality of children's surgical care should be shared across political, economic, and political boundaries. Within the United States, I think all of us should join together in crystallizing this vision, in advocating for and in implementing it. We should lead the way for the world in improving the care for the most vulnerable among us, who also represent the future for all of us. In the words of the great anthropologist Margaret Mead, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Thank you for the opportunity of sharing this adventure with all of you. So it's a little different focus than the typical grand rounds, but I'm happy to answer some questions. Dr. Boyd.
It was a really great talk, and just coming from a sort of place that had universal health care in Canada, I always this argument about costs and resources is what often comes down to it. It's interesting that a lot of the healthcare economists will say in Canada, which is, let's say you have $100,000 you got to spend. Are you going to spend it in surgical care or prenatal care? Prenatal care wins all the time. So I'm just wondering how this effort, although absolutely necessary, how are you going to frame that argument in terms of resources spent and spending it on tertiary or surgical care versus prenatal care, preemptive care?
So, it's an incredibly important question and truly at the crux of what public health specialists, what health economists, what lots of people think about all the time. And it is the reason for the DCP3 effort that's done by the World Health Organization every year to sort of think about this and to think about these hard questions. What the Lancet Commission did, and really Haile Debus started this even before that, was demonstrate for the first time that surgical care can be cost effective. And that, typically all the people, think about the people who go into public health, or think about the people who are sort of at the table at these conversations. They're usually not busy surgeons who are operating. They're the family practice docs and the pediatricians, and it's important. But what this effort did, which is really groundbreaking, is demonstrate that it is actually more cost effective and that you get better return on your investment. Just a financial thing. The disability adjusted life years is better if you fix a kid's fracture than if you try to deliver AIDS medication every day. Because so it takes a lot of infrastructure to go into these remote places and give a compound of 3 pills. And if you miss 3 days of those pills, you might as well wipe out the last 20 years of taking them. So if you do that math carefully and you include all the infrastructure, surgery is kind of cheap. Once you get, some anesthetic stuff and some instruments, labor in many parts of the world is fairly inexpensive. They've also figured out how to task shift and have other kinds of providers. We see this in the military. There are a lot of lessons that we can take that you can teach people to do simple things. And if it doesn't take that much to set that leg properly, but if you don't set it properly, you truly have somebody who now is a burden on society as opposed to a contributor to society. So they did the math, smart economic people. And this is the kind of work that, Laura and Guy and Jamie and many of our young people who are getting their MPHs and thinking about healthcare economics are doing. Cancer care. We've made tremendous strides. Cancer used to be sort of off the table for global health conversations. It's not anymore. And as people live longer, chronic diseases become more of an issue overseas. So it is, we are in the game legitimately now. It's not just sort of scraping for attention because we like surgery, but It's because we can show cost effectiveness. And you can surely show cost effectiveness on the pediatric side of the shop, because you save that kid's life, doing appendicitis, and you got 60 years of productivity conceivably out of them. And if you think about the percent of children in many of these underserved countries, around the world, I have to say, we've eliminated a lot of our adults through war and local other issues that have left children as the predominant population based in many of these countries. So surgery isn't all that expensive. There are hard questions, though. Does every 80-year-old get a VADS and a heart transplant? Those are the kind of hard questions that have to be answered. And the reality is, of course, that the people who vote are like the people like me who are closer to 80 than we are to 25. And so, when you start thinking about it, you're thinking, well, if I did get heart failure, that might be okay. So, and that's why for me it's harder to tackle. We've got Medicare already in place because there was a sense that the retired and the older folks, it was unreasonable to expect for them to be able to buy health insurance. So, I could see that we could, if you brought kids, many of whom are healthy, into that equation, you'd actually bring a healthy population base into Medicare. And so you, in fact, could probably at least double the population of folks we take care of for not as much of a financial hit as you might imagine. I haven't done the math yet. That's why I got these people. It's great to be the chair. And then we have to think carefully about, how are we going to think about the folks in between us right now? And is a meritocracy based, do we want to provide some level of baseline care, but say if you want, several new knees and something else, there's a different payment system for them? I don't know. Really hard, difficult decisions that we need other smart people to make. So thank you for that provocative question and that really long-winded answer. Chris.
Really. Since we're in the capital of California, and with the most recent front page article regarding Medicare or Medi-Cal, and I guess I'm really concerned about the last few slides that you presented because we need to do something. What can we do? Is it a matter of starting at the grassroots again, and starting with California and saying we need to do something different? Do we go to the legislature? Do we get our Northern California chapter ACS and that be part of our lobby day rather than some of the other things that may be at the national level to say we need better funding? And or do we even start Medi-Child here in California?
I don't know the answers to that question, and I really wish, we have 3 tracks for our, our trainees. We've got our sort of surgeon scientist track, our, rural global health track, and then we have the public policy track. I need more guys in the public policy track, because you're right. The next step, it's all great to give a fancy talk about this, but if we're not making it happen, it doesn't count. So figuring how to implement, and the whole world of implementation science and all of that is the next step. And I invite anybody in here with good ideas to think about how to do it. Jamie has actually been goosing me a lot, like put your money where your mouth is, babe. She hasn't. She said it in a much more respectful way. But yeah, it doesn't hurt to write letters to congressmen and other people because they can just throw it away. That's an easy thing. But how many of us actually take the time to do that, to get involved in things that matter to us? So, point well taken, and charge, accepted. I'm not, I haven't been an activist about anything that I can remember since, maybe high high school or junior high, and I'm sure that was an important issue then. But there's no reason why any of us can't get involved in little ways and in big ways. So, yes is the answer. How? I don't know.
I practiced surgery in Australia over 30 years ago, and they had Medicare for all at that time. And I'm not sure how long before that it was established, but it worked quite well. And I think there's little doubt that what we need Medicare for all in this country, or at least some form of universal coverage. I don't think there's any question.
Jack Langer, who has been chief of pediatric surgery in Toronto at Sick Kids, is in the audience and works with us at time. And I know there are many of you who have worked in Canada and other environments. This is being done in England, and most of the rest of the world has figured out a way to do this partially, because each of us knows if we had to be the one, the doctors can't do this. We are trained to do the best for our patient, no matter who they are right in front of us. We can't, at the time of the patient being in front of us, short of war, make those triage decisions. We care for whoever is there. We need society, we need different folks to set the agenda. And then we could provide different kinds of care to different kinds of people. We could do that. We do it already. We just put it under the rug and pretend we don't see it. But we do it all the time. And I'll have to say that for me, this truly was crystallized. I started out with this global health work, but it was being at Shriners. Most of my practice now is at Shriners. That really brought it home to me that, oh my gosh, I really thought we were caring for all these kids. But behind the scenes, our hospitals don't let them in. We do when we see them. We're not the ones that say something, and I'm sure that's true. Our patients who come through the emergency room all get care. We all feel good about that. But there is a giant subgroup in this country, and it's a lot worse in other states than it is in California, that aren't getting care at all. And I'm sure it's true for adults, not just kids. Kids is just the lens through which I see the world. All right. So go off and do great things. Thank you very much, and it's going to be a great year.